It is my pleasure now to introduce the lecture of Professor Amos Korczyn, our good friend, prominent neurologist and scientist, organizer of many neurological congresses, among them the Controversies in Neurology 2018, which will be organized for the first time in Warsaw, Poland, in March next year. The title of his lecture may suggest the neurological UFO. What is hidden behind the title, Medically Unexplained Neurological Symptoms. Please, Professor Korczyn.
Dziękuję bardzo. Thank you very much. Unlike Professor Deutschel, I do speak 2 words in Polish, maybe 4. And I have to regret this because my late mother spoke fluent Polish. She was actually born in the Habsburg Empire, but grew up in Poland, same city, which now is in the Ukraine. But her mother tongue, the tongue that she spoke all the time with her parents, with her siblings, was Polish. I get my name Korczyn from my father, of course, who was born in Vienna, but his father was born in Tarnów, and probably before that they lived in this town, which is called Korczyn, which I visited, Nowy Korczyn and Stary Korczyn. And Nowy Korczyn was a very impressive Jewish town before the war. So thank you very much for the invitation to come here. It's really a pleasure to be again in Poland. I've been here several times in the past 30 years already, or 28 years since I first came, and to see the progress that is has been developed here all over the place, and definitely as seen here in this meeting, this huge meeting, with so many presentations is really very impressive, and I'm grateful to you for letting me talk to you here. And I'm going to talk to you about medically unexplained syndromes, particularly in terms of neurology. And of course, it is all well known. This is ancient history now. The imagined sickness of Molière, or the imaginary index of Honoré Daumier, but it was not only in France that it existed, it was all over the world. And what's in a name? So then we tend to change the terms that we use all the time. Neurosis, neurasthenia, hysteria, hypochondriasis, conversion disorder, and so on and so on. But they all are about the same issue that I want to discuss with you. Some typical terms are soldier's heart, combat fatigue, shell shock, different names for the same thing, Kriegsnervose, post-traumatic stress disorder. And we now, in the modern era, we speak a lot about non-epileptic seizures, post-traumatic stress disorder, fibromyalgia, chronic fatigue syndrome. All of these are different manifestations of the same thing. And perhaps the most common unexplained syndromes are dizziness. We see these patients all the time who complain that they are dizzy, and we exclude hypotension, we exclude, of course, vestibular disease, because this is dizziness and not no rotation involved. People with headache or other types of pain that we cannot find an organic reason to it. People who are just saying that they're weak, they cannot do the things that they are supposed to do, or those with sleep problems. All these people, we don't know what to do with them, really. So the modern medically unexplained syndrome, again, fibromyalgia, systemic exertion intolerance disease, regional pain syndrome, tension headache, chronic low back pain, dizziness, chronic fatigue syndrome, Münchhausen syndrome, and therefore medically unexplained syndromes is a mega-diagnosis, is a meta-diagnosis that we use in different ways all the time. And I must stress that medically unexplained syndromes are common, expensive, and not always benign. There are major causes of referral to emergency room. So stroke, so if a person comes with a stroke and we give them TPA because of hemiplegia, that's fine. We heard, and we'll hear more about this in the next few days. But some of these patients do not have an organic disease. And therefore, this is a problem because not only is this expensive, but it's also dangerous treatment. And of course, status epilepticus, if it originates from epileptic seizure, it's one thing. But if we put the person into a deep sleep by the anesthetist because of pseudo status, not non-epileptic status, which looks like status epilepticus, that's not only expensive, but also dangerous, and we and others have had people who died because of this intervention for a disorder which is so-called non-organic. It all started 150 years ago or so with label indifference and hysteria, and of course we all remember Jean-Martin Charcot and Sigmund Freud, who laid the basis for the modern discussion in this issue. And I want to mention again that label indifference is just the opposite of what we're talking about, because these people did not complain, as the term suggests. They were indifferent to the problem, and yet we're talking about those people who are different to the problem, who are complaining about the problem, and yet we find nothing. So what do we do with this? So coming back to Charcot and our friend Babinski up here, so this was an issue that was raised then, and I must say that reading the literature, Babinski and Charcot did not see eye to eye about these problems that they witnessed there. And this is very well shown or described by Axel Munthe, who was also part of this group, which was in Charcot's study, one of his students. And he, if you didn't read lately The Road to St. Michele, I think you should read it again. It's very interesting, very impressive about how he describes these issues over there. So now we talk about, in those days, about conversion disorders or somatoform disorder, and again to stress that these are exactly the same thing. We use different terms, but what is the conversion? What is being converted? The mind into the body. So somatoform, it takes the bodily form of a mental disorder, so to speak. These are the terms that are being used. In order to diagnose this, the DSM suggests that we have to exclude neurological disease. I don't know how psychiatrists exclude neurological disease, but I try to do this in those cases, sometimes with success, and excluding feigning as a different demand. Now, this is a negative definition. It is a negative definition. We exclude this and exclude that, and then we say, since we don't find an organic basis and the patient is not imitating it, this means that it's all made up by them in a different way, unconsciously. And different negative definitions are always a problem. It's always a problem when we define things not positively, but rather negatively. And for example, when I was a medical student, I heard that duodenal ulcer was caused by psychic stress, psychological stress, and people were sent to have different psychiatric treatment for this, and now we know that it's an organic disorder. So just not having, not showing something does not mean that it's not exist, does not exist. So how do we know that tension headache, for example, are not non-organic? What is the difference between tension headache and migraine? And if you put your mind to it, then the proof that migraine is so-called, to speak, organic and tension headache is not, is because we have triptans. And if triptans cure the migraine attack, this proves to us that it's an organic disorder, and if we were to find something similar for tension headache, then immediately we shall change our mind about the concept. And the same about pseudo-seizures. So we think that pseudo-seizures are coming from the mind because the EEG does not show an electrical activity. But the movements are there, and the movements are caused by the brain, by some electrical activity somewhere in the brain. So what do we mean when we say that it's non-organic? It comes from the brain in either cases. So the DSM also says something in small letters. So the big letters is exclusion of neurological disease, exclusion of feigning, but there's also in small letters, perhaps not demanded, but it is helpful if you could establish a psychological mechanism or psychological basis for it. So we are faced with this dichotomy. The organic, we think, is neurological, and the functional, we think, is psychiatric. What do we say about post-traumatic stress disorder? Do we think that it's all in the mind? Do we believe that there is nothing changing in the brain itself? Of course, we as neurologists know that although these patients are being treated by psychiatrists, of course there is something that has changed in their brain that causes them to demonstrate these manifestations that they have. So we cannot say that these are functional in this sense, and we haven't been able to show so far convincingly that there are organic changes, but I'm sure that there are some indications this way, and I'm sure that there will be more of this. The question that we have to answer is whether, when we speak about a disorder being functional, do we mean that it is psychogenic? How do we know that non-epileptic seizures, that we see these patients and we refer them to psychiatrists, how do we know that it's in the brain, in the mind, that comes from the mind? We don't have a proof for this, and neither does the psychiatrist able to show or to prove that there is a psychiatric cause to this. There is a suggestion that there is a role of stress, and of course, this is true for post-traumatic stress disorder and for mass psychogenic illness, but these are the only examples where we know that stress really evokes this thing, and in others we can assume that there is stress, but usually we cannot find an evidence for this. And when psychiatrists tell us that there is depression there, the question is this it, or is there reverse causality? Because if I were to develop seizures and nobody could treat them, nobody could tell me what they came from, I would become depressed. So the question whether the depression is the cause of the seizures in these patients, or is it a result, is unresolved. And in most patients, I think that there is no good reason to assume that there was depression or anxiety as the cause before the seizures actually started. And of course, this does not explain why these symptoms, why some patients develop seizures and others develop movement disorders, and why it happened at this particular point in time. So these are still questions that we have to answer. So again, non-epileptic seizures and functional movement disorders or paroxysmal non-epileptic seizures and functional movement disorders are different manifestations of presumably the same etiology, mental etiology. I mean, we don't know, what is going on. And so when we say that this issue, these problems are neurologically unexplained or medically unexplained, do the psychiatrists have a reason to substantiate the cause? Are they psychiatrically explained? In most cases, not. So the psychiatrists give us these explanations of hysteria, back to Charcot, or hypochondriasis. So it was in the uterus, then it went up to the liver. Now we're talking about them as supratentorial. I don't know what's above the tentorium, which is non-organic, but anyway. Or through the mechanism, resolution of internal conflicts, secondary gain, stress, and depression. These are all assumed, but none of them has been proven or convincingly suggested. And when I read before this lecture what happened in the about almost 90 years ago, after the Great War, the First World War. When you read what they did in Queen's Square at the time, they did not know any less than we do. We have not advanced at all in these 90 or 100 years. As a point of interest, perhaps, one episode that happened during the Great War was Adolf Hitler, who developed functional blindness and was treated by psychiatrists, and this was resolved, and the important psychiatrist who looked after him, Forster, was executed by Hitler's people in 1933 in Paris in the Night of Long Knives, as they were called at the time. So this is an interesting thing. So the context that we are talking about is that the mind affects the body. Physical symptoms in response to mental states. Of course, this exists. We all know that if we are in stress, if any of us are in stress, we have bodily symptoms. We have tachycardia and maybe sweating and this and that. And we also know that placebos can affect the physical symptoms. So this is again a proof that the mind can affect the body can affect in either of these. So to say that it's all in their mind as we talk about these patients with functional disorder is actually a mind-body problem. It's a monism versus dualism. Do we think that the mind is in the body or is it separate from the body? And this great philosopher, Descartes, and Benedict Baruch Spinoza, a few years later after Descartes, were rivals in this because, as we all remember, Descartes showed that that the mind is situated inside the skull, but it's not part of the brain. It's in the pineal gland. That's where the mind situates. And Spinoza said, no, it's part. The mind is a reflection of the way that the brain works. So in medically unexplained symptoms, we have to differentiate between the etiology and the mechanism. The etiology, we presume, is a psychological factor. Repressed conflicts, as we said before, stress, depression, maybe any other. But the mechanism is completely unknown. So even if we say that there is post-traumatic stress disorder, that the stress caused the PTSD, how did it cause it? What was the mechanism that was involved? And how did it evolve? But of course, we're not so much interested in how a disease started, but we have to know what is the mechanism underlying it now. And this is completely unknown. We don't understand what is going on in the body, in the brain, in the mind, if you wish, when these manifestations occur. So I think that when we speak about medically unexplained, this is actually a euphemism to say that actually this is medically unexplainable. We cannot explain this issue of how the mind affects the body. And treatments that were given, several of them that we give our patients actually have been reviewed and found to be ineffective. So we don't have a treatment for this either. So what is the take-home message? The diagnosis of medically unexplained symptom is made by exclusion. As a diagnosis made by exclusion, it should be made with great caution because we make sometimes mistakes, not frequently I hope, but sometimes we have. Prospective studies did show that some, but only a few medically unexplained symptoms cases turn out to have an organic basis. The patients, however, are the ones that we look after, and they definitely do suffer, whether we call it or not by that name or by another, and they should not be stigmatized. So giving patient disorder a name may help them, but should not confuse us. So if the person complains of pain and we call it fibromyalgia, this is not an explanation. This does not tell us what it is. We don't understand what it is just because we have a name for it, and this must be clear to us. But it helps the patient, because now they don't have to run to another doctor to tell them. If I tell them I don't know what it is, then they will go to another doctor. Perhaps the other doctor will be able to tell them what it is. But once they hear a diagnosis, I think that this relieves much of their stress. It is probably wrong to identify these symptoms with depression. If these patients are depressed or anxious, it might just be secondary reverse causality. It's all in your head, or it's all in your mind, or you had your disease is not real, or pseudo seizures are derogatory attitudes, are derogatory terms that we should refrain from using them if they do not help our patients, and they do not help anyone. So let's not use these terms. The assumption that all medically unexplained symptoms reflect psychiatric disease is unproven. Most cases are also psychiatrically unexplained. And the assumption that medically unexplained symptoms has a psychiatric etiology infers philosophically, it infers dualism. So if we say we are interested in what happens in the brain, but what happens in the mind is not in our domain, it is somebody else, a psychiatrist, this means that we are dualist, that we are going back to Descartes. And so, because there is this paradox, we believe that the hysterical seizures are not organic, yet we believe that the abnormalities, the hysterical abnormalities, are generated in the brain. So if they are generated in the brain, they are in our domain. And the fact that we don't understand them, neither do the psychiatrists, for that matter. So how can we solve the paradox? Medically unexplained symptoms are non-organic, yet caused by brain activity. It's all in the mind is a reflection of the mind-body problem. Monism versus dualism. Those of us who believe that it's all in the brain should be monist, and those of us who believe that there is a separate mind from the body are dualists altogether. So I want to finish by inviting you to this excellent Congress, CONI, Controversy in Neurology, and this is, we heard about the largest European Neurological Congress, but this is the second largest Neurological Congress, which has existed now for more than 10 years, with about 1,000 participants in each. I'm sure that here in Warsaw we'll have even more. You're all invited to come. We shall love to have you. We're going to have their pro-con debates, as well as frontal lectures, and I hope to see many, many of you there. Thank you very much for your attention.